talk about neonatal nasal obstruction, we will cover mainly the congenital causes. So our objective today, we will talk about the clinical pictures of neonatal nasal anomalies, differential diagnosis, clinical presentation, how to diagnose and how to manage. So we will start with nasal breather from 6 to 20 weeks. The difference between the neonatal and the adult airway is that the neonate possess a high larynx, cricoidal cartilage at level C4, long epiglottis, and tongue relatively larger for the mouth. So how to approach a neonate with nasal obstruction? So first of all, we will do a rapid assessment. We will see the level of the consciousness, respiratory rate, airway noise, stable or not stable. If he unstable, so we will have to accomplish and establish airway. We could do either simple oxygen max, CPAP, intubation or tracheostomy. Once our patient is stabilized, then we will go for detailed history and physical exam. We will look for any abnormality. If we find any abnormality, then we will go further with investigation, which include endoscopies, findings. We will see what's our definitive management. So for the history, first of all, we will look for noisy breathing, rhinorrhea, paradoxic cyanosis, which means that the child will have cyanosis. Once he starts crying, it will improve. And this is the cardinal sign for nasal obstruction. We will examination, we will look for dysmorphic feature, we will look for any signs of respiratory distress. We will do a trial of passing of catheter to both nostrils. We will do anterior rhinoscopy, nasal endoscopy, and we will do oral exam. And finally, we will do CT and MRI afterwards. So our first case, we have a female patient sporadic of normal vaginal delivery presented with dysfunctional breathing immediately after nostril. The newborn was intubated and shifted to the NICU. On the 6th day of life, they tried to do extubation but failed twice. Then ENT was required for evaluation. So what our differential diagnosis of neonatal nasal obstruction? So first of all, we can divide it to congenital and acquired. For the acquired, it includes neoplasm, systemic inflammatory diseases, infections, trauma, or iatrogenic. But so the differential diagnosis of neonatal nasal obstruction, the most common cause is neonatal rhinitis. Then we have the septal deviation due to the birth trauma. Then we have Draco-Asistocele, but less commonly it will cause severe nasal obstruction. Then we have congenital nasal pyriform apertus stenosis, mid-nasal stenosis, and spinal atresia. Congenital nasal masses, which include dermoids, the most common congenital nasal mass. Then we have GLIOMA and ENCHEPALOCELE. Other differential will include hematoma, hemangioma, rhabdomyosarcoma, and neurofibroma, which we will not cover today. So we did for this neonate, we found there is absence of compensation on cold spatula test, failure of passing of fixed French catheter beyond 3.5 cm, and nasal endoscopy after section. Okay, so here we can see on the CT that both choana are completely closed. With the retrograde nasal endoscopy, we found that both choana are closed, and in the nasal endoscopy also it shows a blind printed passage. So our diagnosis, it will be choanal atresia. It's the most common congenital anomaly. It's occurs 1 in every 10,000 births. Female of the choanal atresia is unilateral and right side. The exact cause is unknown. The pathophysiology that there is a failure of the recanalization of the nasobuccal membrane in the embryonic life. However, if there was a nasobuccal membrane recanalization, but it was incomplete, quinal stenosis will result. There is a certain medication will cause a teratogenic syndrome causing bilateral quinal atresia, which includes the type. The most common is the mixed, which is bony and membranous, 70%, and then we have only bony, 30%. What is the boundaries of an atretic plate? We have superiorly the sphenoidal bone. Then we have the medial vitrogoidal lamina laterally and vomer medially, and for the inferior boundaries, we will have the horizontal portion of the palatine bone. Char syndrome, Treacher-Collins syndrome, Villo-Cardio-facial syndrome, Krausen syndrome, Apert syndrome, and then we have trisomy 18 and 21. The presentation, it will depend on unilateral or bilateral. If it's unilateral, sometimes misdiagnosed and they will only discover it in adulthood. However, it usually presents late, by 2 years of age. We will have a patient with unilateral obstruction with resisting nasal discharge. Sometimes, for the bilateral quinal atresia, it will present immediately after birth. The patient will present with asphyxia. We will consider any child having bilateral obstruction. If you have apnea, there is no difficulty breathing and failure to thrive as continuous pregnancy. So our gold standard will be CT scan to accomplish the diagnosis, and to look also for another differential diagnosis. We will also allow us to do the measurement of the vomer of the So again, this is the of bilateral quinal atresia. So the measurements include the mean width of the posterior spinal air space, measuring from the lateral wall of the nasal cavity to the vomer. It will be 0.67, 0.6 in newborn, and then 86 by 6 of age, and 1.13 by 16 of age. The mean vomer width will measure 34 below the age of 8. Then we have 0.28 and should not exceed 0.25 in children above the age of 8. So the management, it will depend on is it unilateral or bilateral. We will talk about several surgical approaches and the timing of the surgery. So our emergency management in bilateral quinal atresia, we will use McGurverian nipple or oral airway. Intubation, we will do it for severe cases, and we will consider So surgical repair, for the bilateral atresia, we must do it during the first week of life to establish nasal airway and feeding, while in unilateral atresia, we can delay the surgery up to the age of 1. The surgical approaches, we have transnasal puncture, a transpalatal repair, and endoscopic repair, and then we have balloon dilatation. For the first two, we don't use it commonly these days. For quinal stenosis only. Then we have in the below picture, we have the instrumentation that's used for transnasal puncture, and then we have the transpalatal approach. For the endoscopic technique, it's preferred to use 0.8 up to 4 milli endoscopic endoscope to visualize the atretic plate. Then it will be perforated either under direct vision through the nose using transnasal endoscope if the nasal cavity was narrow. The success rate is high and with low revision rate. Sometimes we use the nasal septal cross overflap technique. This technique have very low incidence of recurrence of the stenosis. Then we have here the advantages for the transnasal puncture. The disadvantage, high recurrence, restenosis, and also difficulty to pass dilated. Advantage, it is short procedure. procedure quickly, and it's less invasive. For the transpalatal repair, it will provide good exposure. However, the main disadvantage that there is more post-operative complications because it can affect the palatal growth if the child was below 5 years. The endoscopic, as we mentioned before, high success rate with low repeating rate. So what is the risk for restenosis, gastroesophageal reflux disease? So we should give the child a PPI, age younger than 10 days at the time of surgery, and if suspicious post-operative endoscopic microdebridement of crustacean. So what can we do to prevent or decrease the risk of restenosis? We can do stenting. Then we can use mitomycin C, which is anti-inflammatory, anti-neoplastic. It's of a new angiogen. Intra-op, we will do a typical application of mitomycin at concentration of 4 milligram per ml. For 4 minutes, it will reduce the scar formation and the restenosis. And the most importantly, we can do the preservation of a mucosal flap without using the stent. So what is the controversy of stent? It's favorable prognosis with less reversion if the stenting is more than 12. However, that the stent prevents stenosis after cannot prevent the restenosis after removal. Stent complication, it can lead to foreign body reaction, increase in mucosal trauma by doing granulation formation and alar erosion and pressure necrosis in the glomerular stitch. For our second case, we have a full-term baby born at 36 weeks by CS. The weight was 3.7 and 9 at 1-5-10 minutes. The newborn presented with multiple episodes of apnea, cyanosis, and feeding difficulty. He was admitted to the NICU because of the severe respiratory distress. However, intubation was not required. The examination was unremarkable, no dysmorphic feature, including midline abnormalities. Further evaluation revealed that the 5 French catheter could not be passed. So we did for this child a CT, and it showed this picture. Okay, so our diagnosis will be congenital nasal piriform stenosis. It's a rare congenital nasal anomaly. It occurs 1/4 of an incidence of a spinal atresia, occurs secondary to bony overgrowth of a nasal process of the maxilla. So the anatomy, the piriform aperture is anterior-most and the narrowest portion of the nasal cavity. It's the bone is superiorly the nasal bone, inferiorly the horizontal process of the maxilla and the anterior nasal spine, and then we have laterally the nasal process of the maxilla. The clinical picture, it will be the typical picture, which is respiratory distress, nasal pharynx, stertor, and chest infection. So it usually happens as an isolated anomaly. However, sometimes it's associated with haloprosencephaly. The spectrum. In this case, there would be a failure of the formation of the 2 lobes of the cerebral hemisphere. So, what is the sign that can actually hint us to this diagnosis? We will find the solitary medial maxillary central incisor. 15% will be associated with brain and vegetary hypoplasia and hypertelorism and craniofacial anomaly. So the diagnosis will be established by a failure of passing of rhinoscopy, will show bony obstruction of the nasal vestibule. We will do the CT scan, which is the gold standard. Each piriform aperture, if it's less than 3 milli, it will be diagnostic. However, for the total piriform aperture weight, if it's less than 8 milli, it will be also diagnostic. The normal total piriform aperture, it should be more than 11 milli. So MRI, we will do it if we find to do it to rule out any CNS abnormality. Again, we can see here in the CT that the total aperture is less than 8. Here it's size 3.6 for both sides. And you can see here that there is a central medial incisor. So this patient, we should go for MRI. The management, usually conservative management, it will be enough. Usually after the age of 6 months, the patient will have improvement in feeding in upright. Sometimes we will use oral airway. We will teach the family about apnea and how to do a CPR. For the surgical repair, we will use endoscopic transnasal approach. Sometimes it is difficult, specifically if the width of the aperture was less than 3.5, so we cannot force the smaller endoscope. The preferred approach is the sublabial approach, of damaging to the nasovestibular skin or causing scarring tissue. And also, after the preservation of the mucosa, we can do drilling to the abnormal bone. And actually, it has been shown that it's not affecting the normal growth of the palate. Here we can see the sublabial approach. We can leave the stent for 1 week, both of it. And after following the patient for 1 year, it shows no affection on the nasal or the facial. We have a child brought to the clinic for evaluation of mass in the nasal mass in the external surface of the nose on the right side. So what's further question? We will ask when is it congenital, so we have to know is it since birth. Then we will ask about the progression, the relation of the size to the crying, pain, any sign of obstruction, which includes snoring, mouth breathing, apnea, recurrent attacks of meningitis, and birth history, antenatal, postnatal, and finally the family history. So our differential diagnosis will be dermoid, encephalocele, and GLIOMA. For the nasal dermoid, it's the most common congenital midline nasal mass. Nasal dermoid represents up to 10% of all head and neck dermoids and up to 3% of all dermoids. Intracranial connection was found in 25% of a nasal dermoid, percent of the nasal dermoid. The location is most commonly found in the as extranasal mass in the nasal dorsum at the osteocartilaginous junction. However, you can find it anywhere from the glabella to congenital. The development, during a normal development, a projection of the dura will be protruded through the fronticulus frontalis or inferiorly into the prenasal space. This projection normally it will be and result in trapped dermal elements. Dermoids occur when the skin elements are pulled into the prenasal space along with the regression of the dural diverticulum. A sinus tract or a mass may be found anywhere from the course of the diverticulum, from clomella to the anterior cranial fossa. Usually, nasal dermoids terminate as a single subcutaneous tract and can sometimes have a hair protruding from this side, and it is pathognomic. Tension of the duct most often passes through the foramen ceca or the cryptoform plates to the base of the anterior cranial fossa. So what is the difference between dermoid, epidermoid, and teratoma? For the dermoid, it will contain ectoderm and mesoderm, so we will have nasal mass containing hair follicles, gland, and superficial gland. For the epidermis, it will only have ectoderm, so it's a pseudocapsule. For the teratoma, it will also component within the nasal mass. For the examination, we will find a pit or sinus tract opening in the nasal dorsum, tuft of hair protruding through it. May secrete sublictuous material or pus if it gets infected. It is low-growing, isolated cyst on the nasal dorsum. On examination, we will find it firm, not compressible, not pulsatile, does not transilluminate, and does not change in size with crying, and you will have number 2, we have the glioma. Glioma, we will have gliocele in a connective tissue matrix with or without fibrous connection to the dura. Does not maintain a CSF field or subarachnoidal connection. Intracranial connection we will find in 15% of the glioma. How it happened by abnormal closure of centiculate frontalis and can lead to ectopic rest of the glial tissue being left exposed. In male, ratio 3:2, location most commonly found as extra nasal mass along with nasomaxillary sutures, not the midline, in 60%. Intranasal mass only in 13%, most often arise from the lateral nasal wall and can pass probe medial to it. This often arises from the nasal septum. Has more risk of the intracranial connection if it was intranasal combined, so it will have extranasal and intranasal components in 10%. So the histopathology, we will find this plastic and neurological tissue and fibrovascular tissue. We will not find an ependymal tissue which can differentiate the gliomas from encephaloceles. So extranasal glioma, we will find it as a small, firm, not compressible, most commonly at the glabella. For the intranasal glioma, may arise from the septum, slow growing and isolated mass. It will look as a polypoidal and pale. Sometimes it will protrude from the nostril. It will be firm, not compressible, not pulsatile, and do not transilluminate, does not change with crying, and does not change in size with compression of bilateral internal jugular veins, which we call it negative Furstenberg test, and does not associate with the sinus Finally, we will have the encephalocele. It's an extracranial herniation of the meninges or the brain. Intracranial connection in all of the encephaloceles associated with congenital anomalies up to 14%. The incidence is 1 in every, it will be 1 in 3,000 to 1 in every 13,000, while in Asia, we will find the incidence 1. It will be originated from a faulty closure of the centiculate frontalis. We will have a persistent intracranial extracranial defect. The type we will have, according to the content, we will have meningeocele, only meninges. Then we have the meningioencephalocele, meninges and brain element. And finally, we will have meningioencephalocytocele. This means it will contain meninges, brain, and part of the ventricular system. Nose, soft, compressible, versatile, trans-illuminate, increase in size with crying or restraining, increase in size with compression. And does not associate with the sinus and intranasal mass that is most commonly of septum, and you cannot pass a probe medial to it. So this is another difference between the glioma and the encephalocele. 75%, which is not related to the nose. Then we have the sinusiceptal encephalocele. It will present as an extranasal mass. It will found in 15% sphingosmoidal encephalocele. It will have 3 other types, subtypes, which is nasofrontal, and it will present as glabellar mass. Nasoethmoidal, which is going to present as a lateral nasal mass. Then we have the nasoorbital as a medial orbital wall lesion. The distinct at the level of the foramen cecum, immediately anterior to the cryptiform plate. Then we have the basal encephalocele. This one will present to in 10%. It will present as an intranasal mass. as the intranasal mass. The subtype will be transethmoidal, which is the most common. Form plate medial to the superior cavity. Then we have the sphenoethmoidal. It will extend through the cranial fossa between the posterior and the ethmoidal and the anterior sphenoid into the nasopharynx. We will have transsphenoidal extending through the open craniopharyngeal canal into the nasopharynx, and finally we will have the sphenomaxillary extending through the superior and the inferior orbital fissures to the sphenomaxillary fossa. Obstruction, if it was present as intranasal mass, repeated infections, meningitis, abscess formation, clouding of the nasal root, hyperthyroidism, and destruction of the nasal bone, CSF leak, meningitis, and rhinitis. Here we can see that there is a precaution of the brain element just medial to the orbits and occupying all of the ethmoids. Diagnosis, the most important thing in any child with midline, because any nasal mass, it will possess the possibility of having intracranial connection. We will do for the investigation CT sinus. It will evaluate the skull base, and however, it will possess the risk of radiation. CT finding, it will show the fluid-filled cyst, soft tissue mass, intracranial mass, enlargement of foramen sacrum, and a distortion of the crista galli. The signs of intracranial the foramen sacrum. MRI, for the dermoid, it will be hyperintense on T1 and iso-intense on T2. This actually dermoid of adult patients having dermoidal cells. For the glioma, it will be variable in intensity on T1 and hyperintense on T2. This is, you can find there is a CT and also the MRI. Will be variable in intensity on T1 and hyperintense on T2. We can see the above pictures is before the surgery. We can see the brain element is protruding to the nasopharynx, and the below picture is post-op. The management, we should do a complete surgical excision, early surgical intervention. It's recommended only if the patients have recurrent infections, and also to avoid the distortion of the nose or pulmonary anatomy. The timing, it depends if it's connected intracranially or not. If it's connected intracranially, it should be operated as soon as possible to prevent the risk of infection. And it should be a combined approach by ENT and neurosurgery. If not connected, we can delay the surgery up to 2 to 5 years to allow the patient time for growth and facilitate the surgical dissection. Entire lesion must be, including the tract, must be excised to prevent the recurrence. However, the recurrence rate is 5.5. Intra-op frozen section should be done to be sure that the dermoid stalk is out. If you cannot be followed to the face, you should send only if you find in the frozen only fibrous tissue, then the stalk should be ligated. However, if you found dermoidal tissue, rhinoplasty is excellent exposure, good cognizance, and allows simple reconstruction of the nasal dorsum. We can also do as vertical midline osteotomies combined with open rhinoplasty for skull face access, and transglabellar approach with the track over the glabella. Here, there is in this journal, we can find the management of midline nasal dermoid in children by the external rhinoplasty done in Al University. They used 7 cases of nasal dermoids, and the surgical approach was external rhinoplasty. They found that only out of these 7 cases, they had 1 recurrence. So it's highly recommended to do the external rhinoplasty. For the glioma, usually excised intranasally, get the sac through. We should have the neurosurgery standby. While for the encephalocele, it will require combined approach, anatomy, and intracranial mass excised and bone dural defect should be repaired. And the extracranial mass, then it will be removed by ENT. And that was the end of my presentation. These are the references that I used. And thank you so much for listening.